So, as I said, we're here today to talk about alcohol and cancer risk, specifically how that impacts those of us here in the Mountain West. The way that our agenda is sort of going to flow today is we will hear from Dr. Dave Wetter here at Huntsman Cancer Institute, and he will talk about specifically the link between alcohol and cancer risk, um, and sort of the behavioral science and cancer prevention. Rob Timmerman is here with us from the Utah Department of Health and Human Services, and he's going to talk about upstream prevention to reduce alcohol cancer related risk. And then we have Rachel Nuss here from the Wyoming Department of Health, who will finish us off with some information about what collaboration looks like with cancer and alcohol professionals, and give some examples of some community-based interventions. And then we have Dr. Ullman with us here today, who's going to share some information about some of our workforce development opportunities and programs that we have here at Huntsman Cancer Institute. And we'll kind of wrap up with some Q&A. So we're really excited for today's agenda. Our objectives for today's webinar are to be able to increase awareness of the link between alcohol use and cancer risk, specifically in the Mountain West region. We know that this is a topic that has been asked about by a lot of you and has been a topic of interest at the national level as well. So we really want to be able to just provide some insights in today's webinar. We want to talk about upstream prevention strategies and what we can do on the community level to collaborate across sectors to reduce alcohol-related cancer risks. And then we want to be able to showcase community-based interventions and workforce development strategies that support sustainable cancer prevention efforts. So here at Huntsman Cancer Institute, for those of you that are attending these webinars for the first time, or it's your first time sort of interacting with us here at HCI, we wanted to provide a little bit of background about the Institute and the area that we serve. So we are the only designated National Cancer Institute here in the Mountain West region. We formalized our commitment to our 5-state area in 2021. We've always received patients from these 5 states, but in 2021, we decided that it was our responsibility to more formally serve these states, meaning make sure that our programs, our research, our treatment, all of those things are being done with these states and these rural communities in mind. So we are collectively serving 17% of the US landmass. And you can see that there are 10.3 million people in this area, 43 American Indian tribes and nations, and over 35,000 annual cancer cases. And so, in these webinars, it's really important for us to be able to bring together perspectives from these 5 states each quarter when we talk. So the Office of Community Outreach and Engagement, this is where I reside and many of my colleagues that are on with us today. What we do in the Office of Community Outreach and Engagement is collaborate with community partners, patients, advocates, et cetera, to address the unique cancer-related challenges in the Mountain West. And really our responsibility is to build partnerships with community-based organizations and help enhance community awareness and education, and bring community voices to the Institute to be able to improve access to care and drive long-term data-driven solutions. But what does that look like and how do we partner with communities? We really work on listening first and making sure that our community voices are reflected in all that we do here at Huntsman Cancer Institute. We build trust through being present in states and traveling to their community events and meetings and things like that, and really making sure that we have a physical presence in each state. And then helping to support their community-led approaches to prevention, education, and care. And I think this webinar is actually a great example of the idea of listening first, and what we're trying to build here through the Mountain West Cancer Collaborative is, we want these webinars to be an opportunity for you to hear about things that you care about. And so when the U.S. Surgeon General's advisory came out on alcohol and cancer risk this year, there was a lot of interest from our community partners about wanting to learn specifically about what this means and what this looks like in our work. And so that was why we put together today's webinar. So we appreciate all of your thoughtful feedback in planning this session. If you're joining us for the first time today, I've mentioned that this is one of the components of the Mountain West Cancer Collaborative, but really the collaborative is a multi-state network that consists of a few different things. We have a monthly newsletter, we have quarterly webinars, and then we have ad hoc action groups that focus on cancer screening, cancer coalition leadership, and community health workers and their role in cancer care. So there are a couple different components to this, but if you would like to be able to receive our monthly newsletters and get invites to our quarterly webinars, please scan this QR code and join us. It's a really great opportunity for peer learning and sharing best practices and just, being able to sort of learn from one another. So I'm going to wrap up my time and hand over the time to the rest of our presenters today. Super excited to have Dr. Wetter with us here to talk about sort of the behavioral science and relationship between alcohol and cancer risk. All of our presenters' information and bios and everything can be accessed on the information that we send out post webinar and that you received in your calendar invites. But Dr. Wetter is a really renowned researcher here at Huntsman Cancer Institute, and we're just thrilled to have him. And Dr. Wetter, I will turn the time over to you.
Great, thank you. Can you go to so let me start with a caveat. I have been working in tobacco control for 30 years. And our center does a ton of work addressing cancer risk factors like tobacco, tobacco, obesity, physical activity, nutrition, trying to promote cancer screening, etc. We have done some work in alcohol. I am not an expert in alcohol, however, although we have done a little bit of work in that space. So I'm going to just kind of talk you through some general overview slides about the link between alcohol and cancer, and then talk a little bit about some of the differences across the Mountain West, because we have an incredibly diverse set of states that we are working with. And with that, let's dive right in. So the number one leading cause of preventable death and disability and of cancer is tobacco. Number two for both chronic disease and cancer is obesity, physical activity, nutrition. Alcohol is the third leading preventable cause of death and disease nationwide for chronic disease as well as for cancer. It increases the risk for a variety of cancers, and I'm not going to go through them. You can see them over there on the right on the figure. But it causes about 6% of all cancers and 4% of all cancer deaths. So it is a major risk factor for cancer. It is one that there is not great public awareness, and one where, frankly, there's not been a lot of efforts around addressing alcohol use in the context of cancer. Next slide. So Allison already showed this. In 2025, the Surgeon General put out a report highlighting that even light drinking increases the risk of 7 types of cancer. That was actually quite different than a lot of the public health messages that had come previously, which often focused on the fact that moderate or light drinking could actually be helpful, particularly around cardiovascular disease. And the data now are suggesting that is not true, probably overall, but most definitely for cancer. And the Surgeon General recommended that we actually put guidelines, warning labels on alcohol products. Those of you who've ever actually looked at a tobacco pack of cigarettes, there's warning labels around cancer and for pregnant women. You see warnings for pregnant women and alcohol use too, but that we should actually be putting these on all alcohol products going forward. Next slide. So here are some definitions of drinking, and I'm not going to walk you through all the text on this, but there's a very simple bottom line, and that is the more you drink, the higher the risk of getting cancer. And that goes from, and typically definitions for drinking include light drinking, which is a max of an average of 1 a day or less. Moderate drinking is typically 1 to 2, maybe 3 drinks a day, and heavy drinking is more than that. And you can see, I'm not going to walk you through the numbers, but the risk goes up for cancer with every level of drinking as you go up. What's actually really interesting is we've known for a very long time that drinking is associated with breast cancer and with some cancers of head and neck, but now we're finding that it also increases the risk for other kinds of cancers as well. So, next slide. It's also has some really detrimental consequences for cancer survivors. And I'm going to walk you through these data. And in some ways, I always find these somewhat shocking, although perhaps when you think about trying to live with the stress of having a cancer diagnosis and treatment and survival, maybe not. But the National Health Interview Survey indicated that about 56.5% of all cancer survivors drank alcohol. That's actually higher than the general population, which is more around a little over 50%. They also reported that over a third of cancer survivors exceeded moderate drinking levels, which is also much higher than the national level for the general population. Reported, and the one other thing I really want to highlight here is that risk factors often cluster, and particularly tobacco and alcohol use. A quarter of cancer survivors who used alcohol were also current smokers. And these actually jibe pretty well with national data. National data suggests that about 10% of the population is a tobacco user, but if you're a drinker, it goes up to almost a quarter of folks. And it's very high in cancer survivors, despite the fact that it has lots of detrimental consequences. It increases the risk for new cancers. And of course, alcohol use can interact with all sorts of different drugs and treatments. So there's problems there as well. And then if you are having symptoms of cancer, related to sores, digestive tract, GI problems, alcohol can exacerbate that. So it's really important, not only in the context of preventing cancer to try to reduce alcohol use, but also to really address it carefully with cancer survivors. Next slide. So here's some data from the Mountain West across the 5 states. I'm going to just, over there, that blue dotted line is the national average for alcohol consumption. The red line is for binge drinking. And binge drinking is typically defined as 5 or more drinks for a man, 4 or more drinks for a woman in a single drinking episode. So they're putting away some alcohol when you're binge drinking. And then heavy drinking is typically defined as more than 2 drinks a day on average for men and more than 1 drink a day on average for women. So you can see that we've got quite a disparity across the 5 Mountain West states, which probably doesn't surprise you. There's very high levels of drinking overall, binge drinking, and heavy drinking in Montana. It's also higher in Nevada, and then lower levels of all three in Utah, which probably not surprising. Utah has a very unique religious culture. And I always like to point this out because I think sometimes in Utah we get a little complacent and think we're doing really great in addressing risk factors like tobacco and alcohol. And I like to point out the Church of Jesus Christ of Latter-day Saints is doing a phenomenal job of addressing alcohol and tobacco use. When you look at folks that are not LDS, you actually often see higher levels of tobacco and alcohol use in Utah. So and then Idaho and Wyoming are somewhere in between, the high levels of Montana and Nevada and the much lower levels in Utah. So next slide. So why these big disparities across states? And I just mentioned, one of them, but you see that there are different drink. I grew up in Idaho, by the way, and a long time ago. So before most of you on this call were born, and there was a very strong social drinking norm in Idaho. Everybody that I knew drank. It was just part of when you were a kid, your parents, etc. And you see similarly strong community drinking social norms in Montana and Wyoming and certain parts of Idaho. And then you often see higher rates of binge drinking in rural areas. The other thing is perhaps not too surprising is that alcohol use is associated with socioeconomic status. And there tends to be higher levels of alcohol consumption in folks that have lower levels of income, wealth, education, et cetera. And then I've already mentioned the cultural factors. You know, there's a strong religious culture in Utah. Consequently, we have very strict alcohol regulations. You can only buy alcohol, for example, at a state licensed liquor store. If you can buy beer at a grocery store, if you want a bottle of wine or hard liquor, you have to go to a state licensed liquor store. If I drive, you know, across the border to my home state of Idaho, you stop at a gas station along the highway and you can buy anything you want. So it's just very different kinds of alcohol laws and regulations. And then, of course, Nevada with gaming and gambling being such a driver of economics, you see much more permissive alcohol laws. And then with respect to treatments, by the way to turn out today, Wyoming. When I looked at the participant in the chat, I mean, smallest state by population, but you've got a lot of people here. So way to go, give you a shout out. Um, uh, Unfortunately, that small population and a lot of land mass means that there's not a lot of access to treatment. So next slide. Oh, that turned out a little goofy. It didn't look goofy when I sent it to Allison yesterday, but there are a bunch of treatments that are evidence-based and work. And what many people are not aware of, there's actually a number of FDA-approved medications that can help people reduce or eliminate their alcohol use. And it's typically, they're called your MAT or medication-assisted treatments, naltrexone, acamprosate, disulfiram. Anybody that knows anything about mental health and behavioral disorders, a lot of the same treatments that are used for depression, anxiety, other behavioral health disorders across other substance uses are pretty common for alcohol too. So evidence-based treatments include cognitive behavioral therapy, motivational interviewing, 12-step facilitation, where we're actually trying to help people get into a supportive community like Alcoholics Anonymous, and then contingency management, which is very effective, not widely used. It essentially means that you're providing incentives for non-use of alcohol. And then finally, most people probably think of alcohol treatments as being, you know, you're going to a rehab facility. But it also includes integrated care where you try to ensure that you can receive substance use kinds of interventions and services in the context of, for example, your primary care. Next slide. We do a lot of work that is more community-based and also do a lot of work in primary care. One of the most effective interventions for addressing alcohol use in primary care is called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. And I'm actually going to go into that. I won't a little more depth here in a couple slides. There are also a lot of the same strategies that we've used for tobacco use also work for alcohol. And I'm referring to tobacco use a lot because one, I know it better. And two, we've been trying to deal with tobacco use in a very serious way for about 60 years. So we have a little bit of a jump start on a lot of the efforts in alcohol use. But we know that making alcohol use more difficult to get by increasing alcohol taxes, by how much it costs, by restricting advertising, by limiting where you can buy alcohol use. And I gave a good example of that earlier, where in Utah it's quite difficult to buy alcohol, and in other states it can actually be very, very easy. So a lot of these same kinds of community programs, policies are actually kind of work across a variety of different substances. Next slide. So here's kind of the general idea around SBIRT, and it's pretty simple. Is that simply when you're going for a primary care visit, it doesn't have to be primary care. It could be an ER, it could be a specialty care clinic, whatever. But typically, you just do a really quick assessment of alcohol use presence, frequency, duration. And based on that, then you can actually try to identify whether the person would benefit from an intensive treatment, from just cutting back, what level of services might be available. And if any of you are primary care providers, I would say that every primary care provider I ever talk to says that in their head they multiply what the patient tells them by about two, meaning how much they actually drink. Um, but then, based on what folks tell them about their alcohol use, the primary care provider can have an enormous, enormous impact. And it doesn't have to, of course, be the primary care provider. It could be a nurse, it could be someone else in the clinic, a behavioral health provider, social worker, et cetera. But I hear from lots of providers that they get very discouraged about addressing substance use because they help their patients, they might reduce or quit for a while, and they relapse. And that's because substance use has been classified for a very long time as a chronic relapsing disorder. It is not easy to get off substances, whatever they may be. And so folks often need to go through several attempts to reduce their use before they're actually successful. Providers, we've got lots of evidence shows, can help people be more successful when they try to do that. So even though you might not be seeing the results you'd like to see, which is, of course, I told my patient to quit and boom, they were done. I got them help, they were done forever. You still have an impact, even though it may take several times before that really holds. And it's also, providers can have an enormous impact on the motivation to actually addressing change in alcohol use. And then finally, the referral to treatment part is just getting people to the right kinds of services. And honestly, this is a part where we do a lot of work because how you do this makes a huge difference. If you hand somebody a note to call this referral, this, service provider, it is very, very ineffective. There's ways that you can automate these referrals to treatment, that you can proactively take away some of the burden on the patient, et cetera, to actually ensure that you get patients the kinds of services that they need. So thank you. Next slide. Dang. Okay, so we're just going to kind of walk through some ideas for reaching rural and underserved populations that might be a little bit different than you might see in a more urban environment or with higher SES folks. And the really obvious one is mobile and telehealth services. I just saw an article actually this morning that said that about 37% of all behavioral health visits now are done via telehealth. So think of Zoom that we're on, could be a phone call, could be a FaceTime, whatever. Um, but it's a way to get around a lot of the issues that we have in the Mountain West, which includes being a very long way from a provider, for example. It's not unusual in this part of the country to have to drive 100 miles or 2 hours to get to a service provider. Um, it's not unusual for there to be a lack. We have a lot of medically underserved areas in the Mountain West, so it's not unusual at all to just not have appropriate providers and easy access. And so there's using mobile health and telehealth is a really nice way to be able to reach into those populations. And it doesn't have to always be direct to patient. Project Echo is a very good example of what's called a telementoring program, which is a program that can help train rural providers in managing substance use disorders. It's been used for so many different things, where you have someone that's, has an established substance use treatment facility, and they can train folks in rural parts of Utah, Montana, Wyoming to actually be able to reach out to their patients and provide them with medicated assisted treatment, et cetera. So next slide. Integrations into primary care. Something like 80 to 90% of folks who use alcohol use see a primary care provider at least once a year. There's not many providers that you see that, that can reach a higher proportion of the population than that. So that's the great opportunity to actually be able to identify and start to help people through programs like SBIRT that we've talked a little bit about. If you're in a large enough clinic or a setting where you could actually have behavioral health services in the clinics, and then actually we just talked about strategies for training providers to do medication assisted treatment. Next slide. Um, so one of the things that is unique about growing up in a small town or living in a rural area is everybody knows everybody. So it can be a little bit intimidating to try to address substance use and things that have a stigma associated with them. So some of the ways you can get around that is actually training members of the community or peer recovery coaches to actually help local residents. And what that does is actually give a layer of confidentiality that you might not see otherwise. And then, of course, there's lots of faith-based, and we have lots and lots of tribes in the Mountain West that have recovery groups and healing practices, and then promoting recovery community organizations. Next slide. I mentioned earlier that alcohol use is associated with lower socioeconomic status, and the stress of living in poverty, of not having a job, of being nervous about losing your job, of having to move around a lot because of financial reasons, increases stress, increases alcohol use. So the more that we can try to help folks address these other issues that contribute to alcohol use, the more likely we are to have an impact on their alcohol use. So those are things like housing assistance, job training, education programs, transportation if they need it, and even things like, I'm afraid it has gone away, but a lot of efforts over the last decade to try to improve broadband access in rural areas, which gives you then access to telehealth in a better way. So next, please. And then I'm just going to end on this slide. There's actually a surprising lack of public awareness of the link between alcohol and cancer. I think most people don't know that it actually has this link. And so there's a real opportunity here for educational campaigns that can increase the knowledge of that. And when we did that with tobacco, when the 1964 Surgeon General's report that linked tobacco use to lung cancer came out, we started doing major media campaigns. We saw a really dramatic drop in tobacco use over the next few decades. So there's a real opportunity there. I'm very interested in trying to address combined use with tobacco. Currently, most substance use facilities will, if you're being treated for alcohol use, will also deal with tobacco. But what's more common is for folks to actually go to tobacco cessation programs, and we usually don't deal with their alcohol use. But it's a great opportunity because if you'll remember the data from earlier, tobacco and alcohol use often cluster together. Great opportunity to improve SBIRT, and I know there's lots of you that are actually trying to do that. So routine screening and counseling in primary care settings. And then, we looked at the regional differences. There's likely very different strategies that need to be used for addressing alcohol use in Montana than are needed in Nevada or Utah or Idaho or Wyoming. So opportunities there to really tailor things. And that is my bit. So I'm happy to take some, I don't know, Allison, if you want to do questions now or put them off till the end or whatever you want.
Sure. Yeah, we'll open it up for questions really quickly while I sort of transition over. One final thought I wanted to give Dr. Wetter, thank you so much for your time. I love that you ended this with the idea of opportunity because I think there's a whole lot of opportunity here. For, a lot of people don't necessarily think about alcohol and think, oh yeah, I could become addicted to alcohol. People think like, oh, that's not something that's going to happen to me. But when you reframe it as alcohol as a risk for cancer, I think a lot more people are willing to like listen because people realize that sort of, you're a lot of people can have an increased risk for cancer and are more likely to sort of listen to those types of prevention messages. So I love that that's how you sort of framed it. Gabby, do we have any sort of questions coming into the chat, or should I move along?
I'll just highlight one thing you said,
Sure.
and I said this, which is I think refraining from using terms that have a lot of stigma attached to them, like addict. It can be really useful because there's lots of people that have a drink or two a day and may not have any major social consequences related to alcohol use, but would still benefit health-wise from a reduction in their use. So you want to stay away from terms that that just are a little bit um, pejorative or have stigma attached.
Yeah, absolutely. Well, thank you so much, Dr. Wetter. Um, I'm excited to be able to introduce Rob Timmerman. We worked together a lot in a former life of mine in substance use prevention, and just thrilled to be able to reconnect and have him present to you all today. We're going to hear some information around upstream prevention strategies and opportunities for collaboration in our communities. So, Rob, would love to turn the time over to you.
Okay, thank you so much. I'm more than thrilled to be able to talk today, and I do have a lot of the same information to talk about, maybe in a little bit different way than Dr. Wetter, and maybe how some of the information that he presented is operationalized, or how we can actually do this work of prevention. And so, yeah, happy to be able to talk today. So let's go to this first slide. So I wanted to introduce this that I affectionately refer to as the prevention pyramid. Many of you, I know that I am singing with the choir. I don't think I'm preaching to, but singing with the choir on some of these things. But I wanted to kind of start with here because inevitably, like when I introduce myself to somebody, and it's the question, like, what do you do for a living? And I say that I do drug prevention stuff. They'll often go to, like, oh, well, my son has a something going on, or my nephew, or my niece, or the kid down the street, um, and and like that's how we kind of begin the conversation, and then I kind of start talking a little bit about what I actually do. And so when I have those conversations, or when someone that has participated in a negative outcome behavior like alcohol use or whatever, and when I'm talking to people and they say that, that's kind of where that middle to upper section of this pyramid comes in. And my work, and the work that I'm hopefully going to do a good job talking about today, kind of lies within that middle to bottom section of this pyramid, and talking about primary prevention and even primordial prevention. Realizing that term primordial prevention may be somewhat new to folks. I'll talk about it in a couple of slides, and kind of really maybe define what that is and how it relates to primary prevention as well. So let's go to the next slide. Okay, so some of you, and again, like if you're in this work of anywhere along that prevention pyramid, and even in talking and introducing this topic as a upstream approach, so you're probably familiar with the graphics. You've probably seen them or even used them yourself, where it is, it's a picture of a stream, and you've got folks on either side of the stream and people in the stream or the river. And the whole concept of upstream prevention is the further we go upstream, and utilize interventions to keep people from getting in the stream in the first place, is that work. And that's what we need to be able to do. I like to imagine it this way, where primary and primordial prevention are even like upstreamier than that graphic, and that graphic that you're most familiar with. It's like up in the top of the snow-capped mountains, where that snow just starts to melt. That's where primordial prevention is. That's where some of the primary, and again, I'm going to talk about the difference between primordial and primary prevention. But that's what we're talking about when we start talking about primordial prevention, is like where that snow starts to melt, and doing things in the first place, so that the snow that lands on the top of the mountains is pure and clean and white anyway, so that downstream we have the ability to utilize that in a healthy way. So I like to kind of set that stage as what I'm talking about with primordial prevention. And we'll go to the next one. So this concept of primordial prevention really kind of started showing up in research literature around 1978, 1979, usually having to do with cardiovascular health. And I think, like, again, this choir that we're all singing we kind of know and understand, maybe from a layman's perspective, at least some of the things we should and should not do when it relates to cardiovascular health. So researchers were kind of looking into some of this. We know this now, of things that we shouldn't do so that we can have healthy hearts, and some of the things that perhaps we should do so that we can assure that we can live a long and healthy life, and that cardiovascular disease isn't going to be a part of our life, right? Um, and and we know that, for instance, adding things to diet can be either harmful or helpful. Taking away things from our diet, things like neonatal vitamins. Researchers were trying to kind of come up with this. We're sure we can prevent some of these things from happening before a child is even born. And talking now again about alcohol with our topic today, we know obviously there's no safe level of any alcohol consumption during pregnancy. We know that, but now we're starting to learn and understand, in terms of overall alcohol use, if we want to reduce the likelihood of disease, again, cancer, as we're talking about today, we should reduce the amount of alcohol consumption that we have. And as we start thinking about, well, how do we actually do that? That's what I'm going to kind of hopefully talk about a little bit again, and go on to the next one. Again, talking about this bottom section of that prevention pyramid, where we've got that primordial prevention. Again, this may be a new term to folks. I love the term because it's kind of um, a term that like is it has to do with like fantasy. I don't know, like video game fantasy, um, that kind of world, primordial. But it's that bottom level, first things that we do, the upstreamiest prevention that we can do. It addresses social, economic, and structural policies and systems that affect health and well-being. And that the moving up the pyramid a little bit, primary prevention is where we can actually implement evidence-based strategies, curriculums, environmental changes that address those problems before they start happening, before they emerge. So let's go to the next one. I love to utilize this quote. This is a quote that I found by Dr. Musharraf Hussain, and it appeared in the Journal of Family Medicine and Primary Care back in 2021. He says, the ultimate means for reducing the burden of chronic disease is primordial prevention. And if you think about that, the more work we do, the further upstream we do it, the better results we're going to have downstream. We're talking about chronic disease or acute disease. And again, talking about cancer, the more we do, the further upstream we do it, the better outcomes we are going to have downstream. Next slide. Okay, so what's the mechanism that we do that? And again, in my area, the field that I'm familiar with in thinking about substance use prevention, prevention of other negative outcome behaviors, we utilize the risk and protective factor theory. Risk and protective factor studied now for 3-4 decades, introduced by Dr. David Hawkins and Dr. Rico Catalano at the University of Washington, the Social Development Research Group. Really for the first time started looking into this drug prevention thing and trying to align it with what we know from public health and utilizing some of the strategies that we understand, again, even from cardiovascular health. There are risk factors that are associated with negative outcome behaviors. and there are protective factors that help buffer against those negative outcome behaviors. And so they really started looking into what we are doing. Everybody understands, and even if you're young, you've heard it before, or you've seen the T-shirts, the Dare T-shirts, or you've heard Nancy Reagan's "Just Say No" type of thing. These researchers kind of started to understand that that sort of stuff may not actually work. But if we start looking to reduce the risks associated with substance use, then we're going to have a better chance in predicting overall behavior and those outcome behavior. If we can reduce the likelihood of those outcomes from happening, then that's where we want to go. As it relates to our conversation now, if we reduce the likelihood of alcohol consumption, we are then going to reduce the likelihood of alcohol-related cancers, right? So again, we're in the choir, we're all singing together. Let's go to the next slide. Okay, I realize there's a lot of information on this slide. You might not be able to see it. Don't worry, I'm going to show you the next slide. It's also going to have a lot more information. You're probably not going to be able to see that. But essentially what this is saying is there are risk factors in 4 domains. These researchers, David Hawkins, Rico Catalano, and now others have been studying these risk factors in the community, family, school, and at an individual level. And they call them domains. And within each of those domains, they've got those individual risk factors. In the community, a lot of it has to deal with how people function in a community, how attached they are to a community, how community laws and norms dictate what happens in a community. Dr. Wetter was talking a lot about the differences in the Intermountain West. Here in Utah, obviously we have some different norms. Some communities, even within the state of Utah, have different norms. And this, as we kind of start understanding how those different norms dictate what happens in the community, we can start attributing greater or lesser likelihood of negative outcome behaviors to happen. But again, the good side, so on the right side, there are protective factors that help buffer against some of those things. So in a community setting, if there are opportunities for pro-social involvement, good things, to be involved in good things, if there are rewards or recognition for pro-social involvement, then the likelihood is reduced of those negative outcome behaviors. Again, talking about cancer, if we can build positive associations with good things happening, and that can help buffer the negative consequences of alcohol and alcohol-related issues and problems. Okay, so the next slide. I promised I'd show you another slide with even more information that was even harder to see. So this is a matrix that kind of takes those risk factors and in those domains, and then aligns them with negative outcome behaviors along the top. And I've utilized that term a lot, negative outcome behaviors. And here's the explanation. Substance use, delinquency, teen violence, school dropout, teen pregnancy, school dropout, violence, and depression and anxiety. So where you see a dot in this matrix associated with that risk factor, there has been multiple studies now that show the relationship between that risk factor and the negative outcome behavior. So let's grab the very, very first one at the top that we see, availability of drugs. In this setting, we can kind of interchange that with availability of alcohol. So if alcohol is available in a community setting, then there is a greater likelihood of that negative outcome behavior happening in that setting, meaning the use of alcohol, right? So that makes sense. I always point out a couple of things here in some of the domains as I talk about this. And in particular, look at family, where we see those negative outcome behaviors. That first risk factor is a family history. We know how important what happens in a family is, and the even genetics of what is happening in a family is, in how it relates to those negative outcome behaviors. I always say, like, the easiest example is if your father had a heart attack and your grandfather had a heart attack and your great grandfather had it, like, I'm so sorry, you have an elevated risk of having a heart attack, right? But again, there's things that we can do to buffer against that risk. There's things that we can do to help reduce that risk associated. And as it relates, again, there's things that we can do to reduce the likelihood of alcohol use and the negative associated health and behavioral health consequences from alcohol use. Okay, I love that Dr. Vetter talked about social drivers of health, and I loved that he used the term social drivers of health. Go to the next slide. Um, I firmly believe with all my heart that these things, when we start talking about social drivers of health, can be dealt with, worked on, reduced, or eliminated. And again, that's why I appreciate the language of social drivers of health, because if something is determined, then that means we probably don't have a whole lot of opportunity to change what that is. But if we have the opportunity to change what's driving these things, then that's the work that we are doing. So again, Dr. Vetter, Dr. Vetter, sorry, Eddie Vetter's in my head for some reason. I apologize. We talked about social drivers of health. And as we kind of can relate those social drivers back to that risk protective factor theory and things that we can work on and things that we can do and change and how we can go upstream all the way to the tops of the mountains where those streams are starting as the snow starts to melt. It's spring. We've got snow-capped mountains. I love to use that analogy. Next slide, please. Okay. So this is the work that we do and can do and should do. And as we're doing this work, hopefully I'm kind of making this argument make sense. We can reduce the likelihood also of alcohol use and therefore alcohol-related cancer and that risk. So the more that we work upstream, the more that we work on safe housing, transportation, and safe neighborhoods, working to change the built environment of the place where our kids grow up, reduce the social norms associated with alcohol use, reduce the again, we know socioeconomically that there are more alcohol outlets in poorer neighborhoods. If we can create opportunities that change that, then again, we'll reduce the alcohol availability, and we know that that's associated with the use of alcohol. The more people have opportunities to further their education, get better jobs, raise their income, the less likely they are to engage in those negative outcome behaviors and can even affect their risk for developing cancers and other diseases and illness later on in life. Food, obviously, more opportunities for nutritious food, physical activity, the more that we can create opportunities in our communities, in families for physical activity, the less those behavioral and health-related outcomes will be negative. And that's the work that we're doing. Polluted air and water. This is a crazy one. There's also some associations between where we live and pollution and water levels. And then there is that relationship to negative outcome behavior, substance use, and other. And again, language and literacy skills. If we can work on these things as communities, as society, and as neighborhoods and families even, the less likely we are to see negative outcomes, and we can reduce that risk. Okay, so I wanted to go to the next one. I'll go to this one really close or really quickly. Here in Utah, we have a student survey, the SHARP survey, Student Health and Risk Prevention Survey. And we ask some social drivers of health related questions. And I wanted to just show this slide as it illustrated as a point to illustrate that those things are created. So what we see here is those that indicate a yes to this situation. And again, I know they're really hard to see. I'm sorry. I'll read them. In fact, I've got, and even on my slide, it's hard to see. So I'm gonna zoom in a little bit and just make it a little bit bigger to see it. Okay, so going from left to right, one or more people living in my home has lost their job. I've had to move or change homes in the past year. I skipped one or more meals because my family didn't have enough money to buy food. I had difficulty keeping up with schoolwork because I didn't have access to a reliable computer or home internet. or I did not have a place to study quietly. And you can see the relationship between those that indicated yes in purple and those that indicated no, and those that indicate yes on some of those social driver type questions have a greater use of alcohol. And so we know from our data that those things are related. And again, the more that we work on those things to reduce that risk, the greater effect we're going to have on overall alcohol use and alcohol-related cancers. Okay, next slide. Let's skip this one. I'm talking too much. I'm running out of time. Okay. Again, here's the pyramid. We're going to talk now about, yeah, let's go. We'll go to the next one. We're going to talk about how that is operationalized and what we're doing. And again, I love Dr. Wetter talked a lot about some of the actual interventions and strategies. And upcoming conversations here in this webinar, we'll talk a little bit more about those things as well. But we know there are things that will work. There are evidence-based things that we know can help in preventing at a primary and primordial level those negative outcome behaviors like alcohol use. Let's go to the next one. Okay, so what I hope to emphasize here is that we all share in this work. This is like really anybody that cares about anything, anybody that cares about their community, anybody that cares about youth, anybody that cares about adults, vulnerable populations, we have a responsibility to work in this together. And how we utilize kind of that desire to help and work together here in Utah is something we call community-centered evidence-based prevention. And we've kind of built our system of prevention here in the state of Utah on that concept. Again, community-centered evidence-based prevention. I might just say CCEBP from now on to shorten it up a little bit, but let's go to the next slide. How we do that is through community coalitions. Community coalition, so a coalition, a group of organizations, a group of members, a group of individuals coming together at a community level really is the best mechanism, the best vehicle to be able to prevent, again, at a community level, some of the things that are happening. Some of the reasons is because we've taken this idea of shared work and we've mobilized it. We've put it into action. We've invited people to come and meet with us and work with us and share in this work together. Another key to that is being able to utilize localized data. What is happening exactly in this particular community that may be different from a community 10 miles away, 20 miles away, across the state border into another state. What is happening that's unique to this place that is contributing to some of the things that we're seeing? And then once we identify those things, we can prioritize because we can't eat the whole elephant at the same time. We got to take off the little bites that we can. And we do that by utilizing evidence-based programs, practices, and policies, things we know that are going to work. So let's go to the next slide. Again, community coalitions are set up to mobilize and organize. Here in the state of Utah, we use a couple of mobilizing and organizing models within community coalitions. And we know that as we organize and do it in that way, that we're going to be more effective. That it's not just bringing a group of people together and sitting in a room and wondering if something's going to happen. It is doing the groundwork to bring the right people into that room and have a strategy and have a structure to that work. And the first way to do that, go to the next slide, is, I love donuts. And so this is just an excuse for me to throw in a slide of donuts. It also, I skipped lunch in preparation for this. And so I'm actually now getting really hungry. But this is a dozen donuts and it helps me remember the next slide. In making up a community, we want to involve as many community sectors as possible. There's a national program with the Center for Substance Abuse Prevention, or CSAP, that recommends 12 different community sectors, hence the dozen donuts. So each of these different community sectors represent the fabric that makes up a community. And it's important to be able to involve all of these people, all of these groups, all of these agencies together in that shared work that we're doing. And so this is kind of a representation of what a community coalition could look like, or maybe even should look like, as we include different community sectors sharing in that work. And that's what those arrows represent, is that shared work. Sure, there has to be a coalition staff person, a director or a facilitator of a coalition, but it's not the responsibility of that staff person to do all of the work that needs to be done in prevention in a community. It's the shared responsibility of that shared work by all of the community coalition members, people that bring in specific experience or skills or strategies or resources even to make sure that that work gets done. And then next slide. And then we've all been a part of strategic planning where we've had the sticky notes and we put them on a wall, or we've put them on, a giant poster board, and prioritize things that we need, things that are important to us, and then probably have gone through a process of picking those things, aligning them, things that are similar together so that we can prioritize. And so this is strategic planning. We've all gone through strategic planning, and as a community utilizes their local data and utilizes a strategic planning method to prioritize what's happening in their communities, then they're going to be better able to tackle the things that are happening in their communities. And so that strategic planning process is super important. Next slide. That helps us get to comprehensive prevention in a community. And next slide. I've already mentioned programs, practices, and policies, but what we want to see happen in a community is is using all of those things in the best way for that particular community. And so this little Venn diagram, I can't remember. But it's that middle part that we want to focus and concentrate on and make sure we're doing a balanced approach to prevention in our communities. Next slide, please. Again, Dr. Wetter, he talked about some of these things already. These are a list of 7 strategies for community change. And so again, in a community setting, if we can grab those people, work together, and have community members, community coalition members implement these types of things, we are going to be better able to reduce the likelihood, reduce that risk, and reduce the likelihood of those consumption or behavioral problems that are happening in our communities. Really quickly, Parents Empowered is something that we do here in Utah. It is our underage drinking prevention campaign. It is targeted to parents. We know that alcohol use is a adult centered thing, right? Can't get alcohol unless you're 21. But we know that people under 21 are getting alcohol. And sometimes, and again, the questions we ask our students in our student survey, sometimes they get it from parents. And so we want to make sure that we are empowering parents with information to know and understand the risks associated with alcohol. Up until now, we've really relied heavily on brain development. But now we have this opportunity to start even talking about the link of cancer. And we know that parents want their kids to grow up safe and healthy. And this is a good way that we can be able to utilize a no underage drinking message by providing more information on some of the harms potentially of alcohol use. Screening, brief intervention, referral to treatment, huge opportunities for primary care physicians. I'll also throw in another one as it relates to providing an evidence-based program where in a primary setting, if a question is asked, do you use alcohol, and a positive answer is given, remember back to that family domain that I mentioned. Parent or family use of alcohol increases the risk of a youth using alcohol. But we can add a buffer by providing an evidence-based family or parenting class. Another a good illustration of that is a evidence-based program by the name of Guiding Good Choices, which was developed to help reduce the likelihood of substance use and other negative outcome behaviors. But we can refer a family into and partner with an organization that provides that guiding good choices class. Let's go to the next slide so I can kind of wrap this up. So this is what this may look like, right? Is we've got these different community sectors all working together to reduce the likelihood of alcohol consumption and initiation among youth, or reduce the use of alcohol in an adult population. And the different colors of these of this coalition graphic now represents different sectors coming together to work on specific strategies or activities related to that reduction of alcohol use, consumption, age of onset for youth, all the while knowing that as we do those things, we will be also reducing the likelihood of an alcohol related cancer later on in life, right? So hopefully I've painted this picture of we can use this work together. We can utilize a community planning and mobilization strategy together. Those of you that are from cancer prevention or treatment or support groups or anything like that in your community, here's my invitation to you to connect with community organizations that may be doing other types of prevention. Again, here in Utah, we have this kind of strategy built out. We've got 67, I think at last count, community coalitions throughout the state. And we are now kind of just beginning to understand the link of alcohol and cancer and this shared work that we have. And so we now before us is like this amazing opportunity to connect with our cancer prevention and cancer workers, can I call some of us that, together in communities to do this shared work. I have a few more slides. I was just going to show, just go to the next one really quick. Actually, okay, so this is our 30-day use rates among all grades in Utah. Alcohol is that green line that was up on top, and now it's dipped below. That's the one that spiked up was e-cigarette use. Just wanted to show like we are working on this. Yes, we started maybe lower than some of the areas here in the Intermountain West with our alcohol use, but we are continuing to work to drive that down to zero. If that's our goal, we don't want any underage drinking in the state of Utah because we know the long-term potential effects. Let's just skip the next one. It's just a closer up one, and I will finish because I know there's going to be some awesome information of like how actually to like do this work in the next presentation. So thank you so much.
Thank you so much, Rob. Great information as always. And folks online, feel free to enter questions in the chat as we get closer to our Q&A period at the end of this webinar. I want to go ahead and transition the time over to Rachel from the Wyoming Department of Health, who I actually works in substance use prevention, but I met her through the Community Cancer Coalition. And so I think that this is going to be a great presentation and demonstration of collaborative work. So Rachel, I'll turn the time over to you.
Great, thank you. Yeah, so I work with the Wyoming Department of Health and Community Prevention. Oh, you can go to the next slide too if you want to already. Our unit oversees substance use and tobacco prevention, as well as we also house the Injury and Violence Prevention Program. So the Tobacco Prevention Program has had a long history of working with the Cancer Coalition in our state, but we started, I feel like over the last year or year and a half, we've really started working even more together, especially on the alcohol side. You can go to the next slide. Our program does work heavily on reducing alcohol use. This is just a graph of the current situation in Wyoming. Alcohol is the most commonly reported substance in Wyoming, similar to most places. Half of adults in Wyoming do report drinking, and then it kind of gets less and less as you go into excessive drinking or drinking daily. Go to the next slide. This is an important slide, I feel like, just for while we have us in every state really in our region does have, usually a lot of community prevention specialists who are working in the counts and the coalitions, like Rob was kind of highlighting in his presentation, who are working on reducing alcohol use. But when you look at the total causes of death, at least here in Wyoming, on average, we're seeing a total of 457 alcohol attributable deaths each year that are because of excessive drinking. 33 of those are alcohol. And so I point this out just to like highlight that while there are a lot of reasons why the Department of Health is working on reducing alcohol consumption, cancer might not raise to the very tip top of our programs as the reason or a focus area for us. And so it is important, I think, to be really intentional with that collaboration, especially as more and more research is coming out about the importance of alcohol as a risk factor for cancer, and just that collaboration might not be necessarily the top of mind for a lot of prevention specialists across the country, really. Maybe coming up a little bit more now that the U.S. Surgeon General's report has come out. Next slide. So in prevention, in addition to a lot of the models that Rob showed, we also work with they call it like the pedals over here, the SPIF model, the Strategic Prevention Framework, and our counties are kind of tasked to be using that model to help guide their work. So when they're looking at alcohol prevention activities, they're kind of working their way through, looking at the data, building up capacity, planning, implementing, and evaluating. In addition to that, we look at these 6 areas. These 6 areas are kind of driven by a lot of the federal dollars that come in for substance use prevention at the federal level. And so my presentation, I'm just kind of going to go through each one of these 6 areas and then highlight some of the work that we've done in the state of Wyoming or that we could do in each of these areas for collaboration between cancer and alcohol prevention programming. Yeah, so the first one is information dissemination, which provides an awareness or knowledge of the nature and extent of alcohol and its effect on individuals, families, and communities. This is something that is kind of easier, one of the easier ones I feel like to do and to start immediately collaborating on. And it's also something that I noticed in the first presentation, again, like not a lot of people really know that link between alcohol and cancer. And so it's an important strategy. It's an easy strategy. And it's one that we've seen already popping up in our state. So one of the programs that we have been seeing for several years is Drink Less for Your Breast, which is a national campaign that's available with a lot of assets and a website that encourages women to drink less because of that link to cancer. Specific for breast cancer. We also have community coalitions who are partnering with their news outlets to do press releases to kind of inform their communities about this link between alcohol and cancer, and they're also putting it on their website. So all very easy ways that you can kind of collaborate together with your local community prevention specialists. Just making sure I didn't forget anything else. Yeah, so just a lot of opportunities there, I think, with, and it's funny too, when I was meeting with Star Jones, who's the Cancer and Chronic Disease Unit Manager here, it was funny when we were originally meeting about tobacco and realized that although we put out a lot of information on tobacco prevention and control, very little of it, if any of it at all, actually even mentioned cancer. So again, it's an important thing to kind of mention. And like was said earlier in the presentations, like it matters to people. And so it's been a really effective tool in getting people to actually want to engage or be ready to hear messaging about drinking less. Next slide. Education is the second strategy that we look at in the prevention world, and this is defined as two-way communication, which involves an educator or a facilitator. I think there's lots of opportunities here as well to integrate cancer prevention messaging and resources in education that's maybe already being provided by prevention specialists across your state. I wanted to highlight a specific program that we have in Wyoming that we just launched over the last couple of months, which is the Let's Talk Wyoming. It's a statewide project that we're using both at the statewide as well as locally, and we're hoping to kind of expand those efforts. Next slide. This strategy includes 3 to 4 minute long videos and associated discussion guides that focus on workplace substance use prevention and mental health messaging. The education is really focused on helping organizations build a culture of health and safety. The project does target construction and then as well as oil, gas, and mining industries, because in Wyoming, those are some of the most impacted workplaces in both substance use and suicide. So it was a natural partnership for our unit, having housed both of those entities. The project also includes some other media assets, including posters and magnets. Next slide, please. So because of my involvement with the Cancer Coalition at the state level, we ended up integrating a lot of cancer prevention messaging into our videos. So we currently have 8 videos on our website. 3 more are slated to come in the next coming months. These topics are all informed by both our data as well as partnerships with our industry. The videos that are highlighted in blue all mention and specifically call out some of the cancer prevention topics as well. And originally, the script for alcohol that was approved did not include cancer as a risk factor for consuming alcohol. However, just because of my relationship with the cancer program and being involved in the coalition, it was kind of front of mind at that time. So in the last minute when we were filming the video, I actually added it to the script and got cancer added to that alcohol video. And so now it does include it. And I remember at the time, all of the production staff was very surprised when I asked for that edit because they weren't aware that alcohol was a risk factor for cancer. And so that kind of solidified the importance to me about intentionally communicating the risk between cancer and alcohol. I think one of the things we talk a lot about in, like, if you think back to that pedal of the strategic prevention framework, building capacity, a lot of that really does have to do with building community readiness. And oftentimes with alcohol, that really means their readiness to hear a message or hear that they want to talk about alcohol. It's one of the biggest struggles and barriers I think that we face in Wyoming, and I would imagine across the region, is that people just don't like to hear that they should drink less alcohol. And so talking about it through the cancer lens has really, I think, increased people's readiness and the community's readiness to talk about the benefits of why you should really opt to drink less. There's additional opportunities as we continue building out these resources in this campaign to continue to talk about cancer as well. So we're going to hopefully be working on adding just some additional assets to let people know about the resources of our cancer, like what the cancer program here in Wyoming is doing. And the benefit to us, like to me as a program and including the Cancer Coalition in this project, is really that they have a list of stakeholders and they have a list of people that they can disseminate these videos to as well. And so it's really a benefit to us to expand our reach. And so that's why it was important for us to include the Cancer Coalition at an early time. Next slide. The video. I think I'll just play just a little bit of this video because I want you guys to see, kind of get a feel of what the videos are like, and then also see if you can hear and listen for cancer being mentioned. It works. Does it work, Allison, if you push play or not?
I'm hearing it on my end. Is it not playing on your end? Let me try.
It's okay if not. I can also throw the link into the chat box so people can watch it after as well.
I'm gonna reshare because I think it probably it pulled up on a new screen. So let me. All right, are you seeing it now?
Yeah.
Okay, let's try that.
We are not hearing it. That's all right. I will throw the link in the chat, and if you guys are interested, you can certainly check it out at a different time. You can go back to the next slide when you get it up. We also, so each one of these videos does come with a discussion guide, and I should have mentioned that the reason we created these are really because these industries are already having what they call safety moment meetings, and so this provides them all the materials that they need in order to just take it and put it into a format that they were kind of already using in their workplaces. So we also made sure to include cancer into those discussion guides as well, so that after they watch the video, ideally a group of these workforce individuals will then be taking the discussion guide and kind of walking through and again discussing cancer and having the opportunity to talk about how cancer is a risk factor for or how alcohol is a risk factor for cancer. So you'll see it right up there, first thing listed. Next slide. Alternatives is a strategy that provides for participation of target population in activities that exclude alcohol, tobacco, or other drugs. This is this strategy isn't one that we use a whole lot in Wyoming, but it is one that can be an effective place for partnerships to attend, contribute, or provide support to an alternative activity. I threw a picture up here of when I actually was working at the University of Wyoming for an alternative to alcohol program. And we brought that gentleman, his name is Mondo. He was the winner of an All-Star Season 1 Project Runway. And we brought him in to judge a condom fashion show and talk about his experience as an individual who was living with HIV. The program that we partnered with at the time was providing on-site testing for HIV at the event. And while this is not a direct link to cancer, I thought it was a really good example of like how you can be really creative in partnering with a program that already exists and in kind of shaping an event that they already have and then spinning it for the messaging that's important to you. So there might be a lot of opportunities to work with just other people in your community that have similar goals. Next slide, please. So environmental strategies are some of, I think, like the most impactful strategies that we can see in prevention because they're so long lasting. They include usually establishes or changes in written or unwritten community standards, codes, and attitudes. So a great way that you can do this is to collaborate on resources or policy developments that address shared risk and protective factors. One of the projects that I worked with the Cancer Coalition Workforce Prevention Group on a little bit was this toolkit for substance use prevention, safety, and well-being in the workplace. It was kind of started actually as an opioid overdose prevention project, and looking at the data, I just saw that there was a lot of overlap to what I had heard in the Cancer Coalition as important policies for both them and important policies that would help us out with opioids. And then in addition to that, it also helps with alcohol as well. And so I utilized the coalition and that work group to help provide input into the toolkit, to help provide input into the specific policies that went into the toolkit. And again, the big benefit to me will be that I will now have a whole coalition who's familiar with well, not the whole coalition, certainly the work group, who's going to be a little bit familiar with this project and willing to kind of promote and disseminate it for us. As an example of some of the policy topics that we included in here that impact both cancer, alcohol, and opioids, I thought the top policy that we need to see changed is some sort of flexibility in work policy to allow individuals to be seen, go to primary care visits. For the Cancer Coalition, it's to be screened for alcohol, for all of our topic areas, really. Encouraging businesses to prioritize that for their staff is important. We also include other policies such as tobacco-free workplaces, sun safety policies, and I feel like all of those are helpful to get a business also to buy into that project. So this is brand new, hasn't even just got it on our website, and so we can't speak yet to the success of it, but we're excited to try and help out some businesses in helping update their policies to some best practices. Next slide, please. And then this one has already been touched on a little bit too, but community-based processes are very important to prevention. Pretty much every model that you'll see will include the Community Coalition. The Community Coalition is a very key piece of prevention work. So the obvious one here is just again to collaborate between prevention and the Cancer Coalition. We have a few of our community prevention specialists who do serve on the statewide Cancer Coalition and help provide input and guidance to some of their strategic planning efforts that they do right now. And of course, our state leadership is also part of that as well. And I do know that some of our local prevention coalitions, so we have a little bit fewer than Utah over there, but we do have one per county. And so there is one in every community that you could reach out to and get involved with, at least in Wyoming. And I would guess every state's going to have some sort of basis for substance use prevention coalitions. And so important again to attend each other's, because me attending cancer coalitions, being involved in talking to that program helps again me keep that connection top of mind, and it's going to be exactly the same reverse. If you attend some of the prevention coalitions, you might be able to advocate for some of those strategies at that local level as well. Next slide. The last one is problem identification and referral. This one you could consider some crossover goals and opportunities to provide resources on cancer prevention. A lot of these strategies tend to revolve around employee assistance programs or sometimes some driving while under the influence programs. And again, just important to maybe continue to advocate for cancer to be a topic of all of the discussions that are coming out of this. Next slide is just questions and also my contact information. Happy to follow up at an email. I'm also, I did throw the Let's Talk Wyoming link into the chat if you're curious about that.
Thank you so much, Rachel. And I loved the visual of like your coalitions across the state. I didn't realize there was so many in Wyoming, so that was really helpful. I'm going to go ahead and just really quickly transition over to Dr. Ullman to talk about our SurTech office.
Yeah, thank you so much. I'm really very happy to be here. Really interesting discussion and educational for me to hear what's going on in this space. And I wanted to come to the meeting, to make people aware of some of the programs that we have that are targeted to learners all across the Mountain West. And I think what I'll do is really just focus on two of my slides, because these are the ones that I would most urgently appreciate your help in helping us advertise and get the word out on. And these are some of the summer programs that are coming up. So I think I'll keep going here. This is kind of just about what our office is. We're really over the training and education within the Cancer Center. And if you go to the next one, next slide really just talks about that our office spans from middle high school up through, we have the graduate students, postdoctoral fellows, so the full range. But yes, you were actually on the slide, one of the slides I wanted to show, so that was perfect. You can go forward one. Sorry, that's confusing. Here's one of the programs that I wanted to tell you about, which is a new program we're starting this summer called Remote Immersive Science Experience, or RISE program. And it is open to high school students. It is a virtual program, but we're partnering with an organization that makes in-home lab kits so that students in the program can perform experiments using fruit flies and really get a full feel for what it's like to run an experiment, analyze data, and present data, and be right in the mix with the scientists that are helping to lead the program. We started this this year with a specific interest in increasing our outreach to rural communities, but I will say a huge challenge is bringing just making people aware in these communities that this is an option for them. And so yes, there's a link here, there's the QR code. Anything you can do to help us get that word out would be great. The registration or the application for this is it's closes on June 1st, so the time is coming up quickly, and the program is in July. It'll really have a focus on what's going on at HCI in terms of research and cancer care, and hopefully we'll get you know, this population really interested in being you know, furthering their education in this area and working in this area. But I think it's also just great to increase awareness and to bolster educational goals. So, and this particular program, we will also pay them $500 for participation in it. So we hope that that offsets, you know, the time commitment that they will have to put into it for this. If you go back one slide, I want to tell you about one other program that is open for the summer, and this is run by the Cancer Center at Columbia University, but we've partnered with them for the past few years by lending administrative support and also having some of our researchers present in this virtual program. This one is purely virtual, so it doesn't have the in-home lab component that I talked about, but it's open to anybody who signs up. They can be middle school, high school, college, and it is a I think it's been a really successful way to get that age group interested in topics that relate to cancer, cancer care, cancer prevention, and cancer research. In particular, our genetic counselors will run one of the workshops in this year's Scientific Enrichment Month. So I also wanted these were the two that I really wanted to make sure people were aware of. I think my slide deck will be in the meeting materials, and it'll give you a little bit more information about the full range of programs that we have, but maybe in the interest of time, I won't go through all of those slides.
Thank you so much, Dr. Ullman. I think, yeah, those two were very, very timely to be able to share, and the slides will be sent out at the end of this meeting so y'all can read about the other awesome programs that our CERTIC office does. We are going to go ahead and close for time's sake. I would love if you all could use your phones and open up this QR code, take our webinar evaluation. We can send it out via email after as well. But any questions or anything like that you have, feel free to email us and we can respond or have the presenters respond via email. But thank you all for being here, and we will go ahead and close off today's webinar. I hope you all have a wonderful day.
Thank you.